Today's module is on lumbosacral or lumbar radiculopathy, commonly called sciatica. This is a terribly painful condition involving back pain, but also pain, numbness, tingling, and even weakness into the leg, sometimes both legs. In a younger patient, it's often caused by disc herniation. In an older patient, it's often due to a condition called lumbar spinal stenosis. You can make the diagnosis fairly accurately with history and physical exam, but the key is to do a really detailed neurologic exam and to utilize your physical exam skills to sort out this diagnosis from competing diagnoses. We'll touch on treatment more when we get to the history and physical exam portion of this module. Lumbosacral radiculopathy takes different forms depending on your age. Younger patients, it's often traumatic, often a disc herniation. Older patients, it's often from lumbar spinal stenosis, a narrowing of the nerve root openings as they exit the spine. Sometimes with older patients, they actually have a combination of both, some stenosis and some component of a disc herniation. The disc herniation cause for lumbosacral radiculopathy is quite well illustrated here. There's a big angry red disc, and this is sort of banging on that orange-colored nerve here, and that nerve will coalesce together to form the sciatic nerve. Sciatic nerve actually being a bundle of individual spinal nerve roots, and that will travel into the body, and when that nerve root is irritated, compressed, or inflamed, it will actually cause a lot of leg symptoms, including numbness, tingling, weakness, and possibly pain. Spinal stenosis is not as well shown on this model, but if you see the spurring here around this disc, that gives you some idea what happens with stenosis. There's spurring from the disc, there's spurring from the small facet joints here, and those all conspire to make the nerve root opening, where the little orange nerve root comes out, more compressed. You can imagine that for those patients who have stenosis, when they're leaning back, that compression of the nerve root would get worse with all that spurring kind of compressing the nerve opening more. On the other hand, with a disc herniation, if you're leaning forward, that would tend to push the disc further back. So that's one of the fundamental differences between these two types of radiculopathy. Stenosis, patients don't like to stand, they don't like to walk because they're in extension. They feel relief when they're bending forward because it opens up that posterior space. Disc herniation, patients often don't like to sit or bend forward because it tends to increase pressure on the disc, and that causes a backwards movement of the disc and inflames the nerve root further. But it's important when you examine your patients to keep that in mind. Depending on their age, depending on their presentation, depending if there's trauma, you can help decide whether radiculopathy, if you find it, is more from stenosis or more from a disc herniation. A couple things to keep in mind when we go to physical exam. I'm going to examine Jennifer here. We typically have the patient standing first. And again, with lumbar disc herniation, as they flex forward, they'll often get pain, let's say it's on the right side here, into the right buttock and even sometimes into the leg. Usually it's more severe disc herniation causing that much symptoms when they're just bending a little forward like this. If we have them sit for lumbar disc herniation, often we do a sitting straight leg raise or slump test, and that will cause pain in the back of the leg and even down to the calf and foot. One of the ways you can clinch the diagnosis, you'll actually have the patient bring their head down. This is called a slump test. And that will actually tug on the dura mater, the tough mother, that is the sheath of the spinal canal, and that will often make worse this sign of pain down the leg. We call that a dural stretch sign. Interestingly, with stenosis, you don't find a worsening when they have a straight leg raise like this. If anything, they might find this a relief. Going back to standing up with the patient, if they went into extension and you're expecting stenosis, they often will get a localized pain into the buttock area and occasionally all the way into the leg, but not terribly sensitive. This diagnosis doesn't depend as much on lumbar range of motion as it does on the neurologic exam and the history. I'm going to have Jennifer lie here on her back. Head over here, please. And when I do this part of the exam, I'm going to examine the hips at the same time that I examine the lumbar spine. It's more efficient. So typically I would do a straight leg raise. And if there is lumbar radiculopathy from disc herniation, that'll cause pain down the leg. Sometimes that's, tight hamstrings as well, but typically that would be more symmetric and not both sides. Typically, if you dorsiflex the ankle, that'll actually make that stretch sign worse. And then I would typically put the hip through range of motion just because I'm screening for other things. So hip external rotation, internal rotation, those should be fairly well preserved with radiculopathy, although sometimes external rotation can cause more localized buttock pain. In terms of the neurologic exam, we cover that elsewhere, but hip flexion, holding the hip up, that will typically be strong, or if it's weak, it's just sort of painful because while they're holding this up, there's extra stress on those lower lumbar structures. This doesn't really help clinch or detract from the diagnosis. Knee extension, put the knee straight as you can here, straighten it up, no, straight. And that should be fairly strong with most forms of radiculopathy. Occasionally, if it's a higher nerve root like L3, the quadriceps will be weak and there'll be weakness with extension. The key is when we get to these muscles down here, bring your ankles up. The patient will try to hold the ankle up. With something like an L4 radiculopathy, there will be weakness of ankle dorsiflexion, and I can actually bring the leg down. You can confirm that by having the patient do heel walking later in the exam. And then the most important muscle, actually my favorite muscle, I call this the poor man's MRI scan, is EHL, extensor hallucis longus. I'm going to take a sock off if you don't mind. Extensor extends the big toe. Hallucis is our fancy word for the big toe. And longus because the muscle that controls it is actually embodied in the calf and not in the foot. So I have the patient hold the big toe up and I would try to pull down. And patients who have radiculopathy have a very subtle weakness. And you have to really examine this carefully. Sometimes you have to hold the metatarsal as you bring the big toe down. And you compare obviously to the two sides. I call this the poor man's MRI scan because honestly it tells me about as much as a patient's neurologic status as a fancy MRI does. What we will also find often is when you do a pinprick exam, there'll be decreased pinprick sensation, occasionally increased, but mostly decreased in the lateral calf for L5 nerve root involvement, or S1, or more occasionally L4 on the inside of the calf. So sensory exam is reasonably helpful here, but not super helpful. In terms of the reflex exam, everyone loves doing reflex exams, but they're usually not that helpful. For L3 radiculopathy, which is relatively rare, the quadriceps reflex would be decreased. But the ankle reflex in S1 radiculopathy is generally affected, and it will be either reduced or absent with an S1 radiculopathy. If you're not sure if the patient is giving you full relaxation, you have them take their hands like this, and you say pull. That's called the Diagnostic maneuver. Some patients are so anxious when you're coming at them with a hammer that you have them do this maneuver. You say, okay, pull when I say pull, pull, and then you do it, and that ensures full relaxation and kind of a decoupling of spinal cord from brain. So that's what you would do there, and then you'd have the patient go onto their stomach. Do you mind, Jennifer? And we're going to palpate very specific structures. Actually, first I'll do knee flexion or hamstring strain, and typically hold the leg like this and be as strong as you can. That will be strong. It's almost always strong, except for rare knee problems or radiculopathy. So this is your second helpful muscle for radiculopathy. Okay, so assuming there's a radiculopathy on the right side, hold it up, be as strong as you can, and she'll be weak. If you test the hamstrings, like many people do while the patient's sitting, you're wasting your time. This is the way you test the hamstring muscles. You have to put them in this position to detect weakness, okay? And you have to really hold. If you test here, you're not going to get a good exam. You have to test up here, maximize your moment arm, and really put some stress there. In terms of palpation, there'll usually be tenderness in the lower lumbar spine where the radiculopathy is present, or at least where the lesion is, and not as much out to the PSIS. I'm not going to examine this in Jennifer as much as I will in the model, which is probably more useful. So Jennifer, you can sit up. But assuming this is your patient, there would be tenderness in this medial or close to the center part of the lower lumbar spine and the paraspinal muscles shown here. If there's tenderness further out, like at the PSIS, posterior superior iliac spine, you think of competing diagnoses that could mimic radiculopathy, like SI joint injury. SI joint injury, as I've discussed in the SI joint module, can mimic radiculopathy. It does cause a sciatica. But the key is on exam, you would not get the weakness generally of the EHL muscle with the SI joint, but you will with radiculopathy. And you'll have more tenderness here at the PSIS when you're pressing because that puts stress across the sacroiliac joint and not as much with the medial part of the spine, which is more with radiculopathy. Important to make this diagnosis. Patients can suffer for a while. Sometimes they're told they have a hamstring pull or bursitis of the hip or SI joint injury, but in fact they do have radiculopathy with neurologic findings. The other thing you'll find is with disc herniations, they'll generally be worse with coughing or sneezing because it increases pressure in the epidural space, but not so much with stenosis. The classic piece of history on stenosis, the grocery cart sign. I've had patients believe that I'm stalking them. I say, you like the grocery cart in the store, don't you? They go, yes, how did you know? Or do you like the grocery cart? I love the grocery cart. Because the grocery cart allows the patient with stenosis to kind of use it as a cosmetic walker. You know, they don't have to bring attention to themselves. They can just walk with this grocery cart a little forward, and they can tolerate walking so much better. I might add on a personal note, I had spinal stenosis. I needed to get surgery a few years ago. And one day I was in the supermarket, and guess what? I had the grocery cart sign. I kind of knew that was time to finally see a surgeon. Surgery is helpful for stenosis. Other modalities tend not to be as helpful. Needless to say, I tried a lot of other treatments. For disc herniation, if they can wait it out, they often will improve. There are various other modalities, McKenzie exercises, spinal mobilization, activity avoidance. We tend to use epidural platelet-rich plasma in our clinic. We used to do steroid injections. We don't like them as much. But these are some possible treatments. There's spinal decompression. A number of chiropractors like this. And sometimes it's just avoiding activities until this can cool down. The disc herniation patients, as I stated, they don't like to sit, and the stenosis patients don't like to stand or walk.